Hello! Today I will be discussing postpartum depression and its effects on motivation. Postpartum depression is categorized as a postpartum affective disorder and often grouped with two other disorders, postpartum psychosis and the baby blues. I'll be focusing on postpartum depression, however it's important to touch on the baby blues, as the baby blues can be a risk factor for postpartum depression. The baby blues is an incredibly common disorder which affects up to 80% of mothers, and it includes mild depressive symptoms including tearfulness, lack of energy, and more. And usually these depressive symptoms resolve on their own within about 2 weeks. However, 20% of patients with the baby blues go on to develop postpartum depression. It's also possible for patients to go through a period of wellness after giving birth and then slowly developing postpartum depression. This is especially common for men, who often develop postpartum depression within 3 to 6 months postpartum. Postpartum depression is largely classified by the DSM-5 exactly the same as major depressive disorder, but one key difference is that the onset must be either during pregnancy or in the 4 weeks following birth. However, it's important to note most clinicians recognize postpartum depression as any depression occurring within 1 year postpartum or during pregnancy. There are a number of factors that can contribute to the onset of postpartum depression, most importantly, the previous history of major depressive disorder or a major depressive episode, but many other things can lead to postpartum depression, such as a complicated pregnancy, a complicated birth, any health or mental issues with the infant, issues with a partner or a lack of a partner, as well as many other things. And especially in women, there is something known as a psychoneuroendocrine vulnerability, which means there's a combination of social, neurochemical, and hormonal factors contributing to the onset of the disease. Postpartum depression is an incredibly common disorder and therefore very important to study. 10 to 20% of women will go on to develop postpartum depression after giving birth, and 10% of men will go on to develop postpartum depression. Additionally, if one's partner develops postpartum depression, they in turn are more vulnerable to develop postpartum depression themselves. Postpartum depression is known as the most common complication of childbirth, and for some people, this is their first experience going through a depressive episode, which can be extremely distressing in the postpartum period, which is already a very stressful time. This can create both immediate and long-term hurdles for the family, and so it's important to discuss it and study it as well. It's important to study it because there are a myriad of ways it can come on, and there are a myriad of ways it can present itself, so we need to really nail down how we can universally help these people. Similar to major depressive disorder, PPD can create dysregulated motivation in many basic needs such as food, sex, etc., goals. But when it comes to specifically postpartum, it can create less engaged parents, less face-to-face contact with baby, less vocal and visual communication, and all of these factors are incredibly important for the baby's learning techniques, for communicating, and for play. And additionally, there's less enrichment activities such as reading, singing, playing games, and disrupted caregiving activities. We know that parents affected by PPD are less likely to breastfeed, and when they do, they're more likely to stop breastfeeding earlier. And as well, they are less likely to take their babies to the normal well baby visits, and this in turn leads to higher emergency room visits later on in the baby's life. In 2018, Root and Knott Maiman studied 90 heterosexual couples' prenatal autonomous motivation to have a child's effect on postpartum depression. They based this study off the self-determination theory of motivation, which we discussed in class, and it involves the 3 basic psychological needs of autonomy, competence, and relatedness. This study specifically focuses on autonomy's role in a healthy psychological state. They hypothesized that prenatal autonomous motivation has an inverse correlation with developing PPD, not only for a patient, but also for their partner. They tested these couples with the motivation to have a child scale, which uses both a positively autonomous motivation and a negatively autonomous motivation. And those two categories involve, for positive, intrinsic motivation and identified motivation, and for negative, introjected and external motivation. In this context, an intrinsic motivation might look like, I've always wanted to be a mother, I've always wanted to be a parent. Identified motivation might say, it's been my goal for a long time to have a family. Introjected might be, I'll be a failure if I don't have a kid. And an external motivation might be something like a social or family pressure, like all my friends are having kids right now, so I should too. Root and Knott-Maiman found that autonomous motivation to have a child is correlated with less depressive symptoms for both the participant and their partner. You can see on this figure here that relative autonomy index is negatively correlated with T2 depression, which is postpartum depression in this study. Interestingly, it's noted at the bottom there, T1 actor depression is prenatal depression, or having previous experience with depression, and that is very positively correlated, as well as a high-risk pregnancy, which we talked about earlier. The treatment options for postpartum depression look fairly similar to the treatment options for major depressive disorder. There are pharmacological treatments such as antidepressants, which, unlike the stereotype, are often very safe for breastfeeding, especially ones like citrulline have been proven to be safe for breastfeeding mothers, as well as psychotherapy, either CBT focusing on catastrophic thoughts around your baby or yourself, and interpersonal therapy, especially focusing on relationship stressors. There are a number of limitations in the research on postpartum depression. First and foremost, it is often limited to only women when we know that anyone can get postpartum depression after having a child in any capacity. And there needs to be more of a dyadic approach used in the research. Additionally, there's often only heterosexual couples and a lack of cultural diversity, and this is often due to convenient sampling and a pseudo-experimental design, as you obviously cannot assign someone to have depression and you cannot assign someone to have a baby. So it is difficult, but there are definitely ways which we can do better. Additionally, there are many challenges in the field working with postpartum depression. First and foremost, there's a widespread call for universal screening, not only at OB-GYN visits, but at pediatric well-care visits up to a year after birth. These screenings are not widely used, although they very much should be, and there are now measures such as the Edinburgh scale, which can be very easily and quickly implemented. Additionally, PPD is not limited to one pathology, and therefore there is not a universal prevention or treatment method, unfortunately, as well as there are a lot of comorbidities and there are a lot of natural stressors in the postpartum period, which makes it hard to parse out what is PPD, what isn't, and how can we treat these people and help them out. All in all, it's important to note that PPD is a family issue. It's not a woman's health issue, and it's important to start a conversation. We need to reduce the stigma and allow these families to have compassion and as much support as they need, as this is already a very stressful time and it can lead to a lot more stress than necessary when someone is experiencing PPD. We should encourage expecting parents to develop a relationship with a therapist before birth, especially if they're prone to the risk factors, and offer social support. We need to continue studying this topic with a more inclusive and family-oriented perspective, and make sure we're involving everyone in the conversation.